Hello, my dear future nursing officers. Welcome you all to the Master Nursing classes. So, in the today's very important session, we will discuss the very important questions concept and a very important golden point chanting and revision for our upcoming Norcet exam. So, here I am giving such a very important and high yield content quick revision. In a short period of the time, we are covering the huge points and huge topics for our upcoming exam. So I will give my best and my maximum in this particular video. So I want every one of you to take a note of the golden points what I am telling, and where I am telling it is important. So just make a note of that one and give the best shot in your upcoming Norcet exam. Okay. So a very good evening to everyone and who all are joined to the live session. So do like to the session, and if anyone of you are new to the Master Nursing classes, so please do subscribe to the Master Nursing classes YouTube channel. Why? Because here we are giving the quality content in a short period of the time. The huge subject and the questions and the concepts are covered for your upcoming Norcet exam. Definitely it will help if you people are following the wherever the thing I am telling important. So that one, right? So yes, a very good evening to everyone. I hope my voice and video is everything is clear, and we will start the video without wasting the time here with this powerful motivational line. So students, if you want to get a best view, just how to go across some hurdles and some bad times and some hard times. Okay, so why? Because the best view comes after the hardest climb. Okay, every one of you know that success is not simple. If it's simple means it would have become a part of the everyone's bag. Okay, so it is not a part of the everyone's bag, because it is a part of only a hard workers, and it is a part of the only a peoples or the students who are the very disciplined about their studies and who are actually want a particular job. Okay, so that is the reason I want everybody you like my especially my students to work hard in this particular crucial time without wasting a single minute of the time. So because it will give you a definite result, right? Yes, even if you have not studied the things in the past, so this is the time just you have to focus on your goals, and just you have to focus on your study, and whatever the content I am giving, try to revise that one multiple times. Yes, because it is the important thing, right? So without wasting the time, we will start the today's session. Okay, so here is the simple information to every one of you, and who all are preparing for the Norcet 9, and if you are searching for a good test series with including the NCLEX based questions, practical questions, and scenario based questions, priority based questions, nursing management questions, and the questions which will seen in your computer screen in the exams. So if you want to become a part of that practice, so just do download the Master Nursing Classes app and subscribe to this particular Super 60 test series. Definitely it will give the best result in your upcoming exam. Okay, and for the updates and for the daily quiz, you can join our WhatsApp group and Telegram group. Okay, so link I have given in the description box, right? So without wasting the time, we will start the today's session, and here is the first question comes in front of you all. Okay, so yes, I know many of you will have the fear of the big questions. Students, don't get fear of the big questions, because these big questions will give the more than 2 or 3 clues to choose the correct answer. So what happens in the one liner? In the one liner, students, you will get the one questions and you will get the 4 options. Okay, if you know, you can choose it and correct. If you don't know, you can leave it. So this situation will be created in the one liners. Okay, and if you found these particular big questions, it will give a more than 1 clue to choose the correct answer. So that is the reason I always used to tell my students, love these big questions and scenario based questions, because it will create the ability to think more, and it will create a like capacity to implement the knowledge in the question. Okay, so that is the reason you people have to go across this kind of the questions, and believe me, definitely you will get at least a 20 to 25 questions like scenario and NCLEX based and practical based questions in your upcoming Norcet prelims exam, and merely about 40 questions you will get in the mains exam. Okay, so it's my prime responsibility to expose every part of the these particular questions to every one of you. So that is the reason I have brought these big questions. Okay, just do read the questions. Okay, relax, do read the question completely, and answer is there in the question only. Okay, so just try to understand the question. So let's start the discussion. Okay, so and if any one of you know the answer, so please put your answer in the comment box. Okay, very good evening beta, very good evening. So try to put the correct answer in the comment box. Yes, the question is simple. Here the 28-year-old woman, she presented to the emergency department. What happened here? A 28-year-old woman, she came to the emergency department and she is complaining that there is the suddenly onset of the lower abdominal pain is there and vaginal spotting or the vaginal bleeding is there. Okay, and her last menstrual period is of the last 6 weeks ago and her urine pregnancy test is positive. Means she is a 28-year-old lady. Okay, and she is in a state of the pregnancy now. Okay, she is in a state of the pregnancy, right? And her urine pregnancy test is positive, then only we are telling she is in a state of the pregnancy. Okay, and since from the last 6 weeks she is having the amenorrhea, so this is also thing which supports the she is a pregnant lady. Okay, so then but after the transvaginal ultrasonography, so we are doing the transvaginal sonography. In that one there is no any intrauterine pregnancy is there. Okay, and small amount of the free fluid is seen in the pelvis. Okay, and the mass is noted near the adnexa. So what is the adnexa, sir? Adnexa means, what is the adnexa? Adnexa means it is in the word we can call together for the fallopian tube and the ovary. Okay, so ovary plus fallopian tube including we call as in the adnexa. Okay, adnexa mass means a mass in the fallopian tube or in the ovary. Adnexa tenderness means a tenderness in the fallopian tube or in the ovary. Okay, so that is the very important point, so just consider and keep in your mind, right? So adnexa means now she is having the mass near the fallopian tube or mass near the ovary. Okay, so based on this presentation, what is the site of the ectopic pregnancy here? Okay, so understand what is the ectopic pregnancy. Ectopic pregnancy is, yes, what is the ectopic pregnancy? Ectopic pregnancy is site of implantation is other than uterus, other than uterine cavity. But normally, okay, normally what happens, this is the uterus. Okay, so consider this is the uterus and this is the cervix. Okay, so here is the vagina. Okay, so this is the normally what our anatomical structure is like this in the female. Okay, so usually the implantation will happens in the upper and posterior part of the our uterus. Okay, so usually implantation should happens in the upper and posterior part of the uterus. So this is the normal location. Yes, if it's happening in the uterine cavity, there is no any problem. Okay, here it also it can happen anywhere, it can happens in the uterine cavity. So that is the normal pregnancy what we can say. Okay, so if in case this implantation which is happening other than the uterine cavity, like in the fallopian tube the implantation is happening. Okay, so in the cervix the implantation is happening. Okay, on the ovary only the implantation is happening. Okay, or in the abdominal cavity, in the peritoneal cavity implantation is happening. So this particular situation we call as in the ectopic pregnancy. Okay, so site of implantation is other than the uterine cavity. Okay, so implantation is not happening in the or uterine cavity, it is happening other than the uterine cavity. We call this one as in the ectopic pregnancy. Okay, so if the site of implantation is not in uterine cavity, means we are doing the transvaginal sonography, means what we will get? So we will get the no product of conception visible. Okay, so why? Because it is not implanted in the uterine cavity and we are visualizing the uterine cavity by using the transvaginal sonography. So obviously in the uterus there is no any product of conception. Okay, and we are getting the mass near the adnexa, means mass, we are getting the mass in the fallopian tube. So what is the most common site of the ectopic pregnancy? Yes, if anyone is asking the question, most common site of ectopic pregnancy is fallopian tube. Okay, so that is the reason this ectopic pregnancy sometimes we also call as this one as in the tubal pregnancy. Okay, so we call this one as in the tubal pregnancy. What is the tubal pregnancy? Tubal pregnancy means implantation have been happened in the fallopian tube. So this is what we call as in the tubal pregnancy. Okay, so very important and very simple question. Remember. Okay, what is ectopic pregnancy? Yes, the ectopic pregnancy is the pregnancy where the site of implantation is other than the uterine cavity. It may be in the fallopian tube or it may be in the ovary. Okay, so overall most common site of the fallopian ectopic pregnancy is the fallopian tube, and the second most common site. Okay, second most common site is the ovary. Second most common site is ovary. Very important, keep in your mind. Second most common site of the ectopic pregnancy is ovary. Overall most common site of the ectopic pregnancy is the fallopian tube. Okay, so remember, right? So here is the structure of the fallopian tube, and here we have the first part of the fallopian tube. So this one, what I call this one is in the interstitium. Okay, so this one I call this one is in the interstitium, and second part is the isthmus, and the third part is the ampulla of the fallopian tube, and the fourth part is the infundibulum. Okay, and these finger-like projections of the infundibulum, we call this one as in the femore, and this is the ovary. Okay, so remember, ovary is the second most common site. Okay, second most common site of ectopic pregnancy, right? So fallopian tube is the overall most common site of ectopic pregnancy. Sir, in the fallopian tube we have these many parts, sir. Sir, we have the interstitium, we have the isthmus, okay, and we have the ampulla, and we have the this particular infundibulum. Among these all parts, so which one is the most common site, sir? Yes, among this all, which one is the most common site, sir? Whether it's interstitium is the most common site, whether isthmus is most common site, whether the ampulla is most common site, or whether the infundibulum is most common site. Yes, which one is the most common site? Beta, the most common site of the fallopian tube in the tubal pregnancy, most common site is the ampulla. Okay, so this one is the first most common site, and the isthmus is the second most common site. Okay, and the infundibulum is the third most common site, and interstitium is the fourth most common site. Okay, so remember, overall most common site of the ectopic pregnancy is the fallopian tube. In the fallopian tube, the most common site is the ampulla of the fallopian tube. Okay, so some golden points you have to remember here. Okay, so most common site of the ectopic pregnancy is the fallopian tube. In the fallopian tube, which one is the most common? That is the ampulla of the fallopian tube is the most common site. Okay, so then the question number second, the widest and the longest part of the fallopian tube is, yes, fatapat do comment your answer in the comment box. The widest and longest part of the fallopian tube, yes, this particular ampulla is the widest and longest part of the fallopian tube. Okay, so ampulla is also known as the largest part of the fallopian tube. Okay, so do remember the very important question. Widest and longest part of the fallopian tube, again answer goes to the ampulla of the fallopian tube. Very important. Okay, and the narrowest part of the fallopian tube is the interstitium. Interstitium is the narrowest part. Very important, keep in your mind. Okay, so the next question is, arrange the part of the fallopian tube in the decreasing order, okay, of the incidence of the ectopic pregnancy, where I already told ampulla is the most common site. After the ampulla, isthmus is the second most common site. Okay, after the isthmus, infundibulum is the most common site. Okay, after the infundibulum, last one is the interstitium. Interstitium is the last one. Okay, if someone is asking the question, most common site of the ectopic tubal pregnancy, most common site in the ectopic tubal pregnancy is the, yes, in the tubal pregnancy most common site is ampulla, and least common site of the tubal pregnancy, least common site of the ectopic pregnancy in the fallopian tube is the interstitium. Very important, two important questions here. Okay, so hope it is clear. And the second most common site of the ectopic pregnancy overall, I already told, the second most common site of the ectopic pregnancy overall is the ovary of the fallopian tube. Okay, so this is the, sorry, not fallopian tube, so this is the ovary of our body. Okay, so the second most common site of the ectopic pregnancy is the overall, that is the ovary. So very important. And the least common site of the ectopic pregnancy is the, yes, that is the, anyone want to answer the least common site of the ectopic pregnancy? Fatapat do response. Yes, that is the cervical ectopic pregnancy. Cervical ectopic pregnancy means the ectopic pregnancy site is in the cervix. Okay, so this particular cervical ectopic pregnancy is the least common type. Okay, so very important. Already I have told, again the golden point revision, the overall least common site is cervical ectopic pregnancy. Overall most common site is fallopian tube. Overall second most common site is ovary of the body. Okay, so that's the very important questions for you all. Right, here is the next question, and I want your active participation and the good answer here. Right, so sorry, let me comes to the first question here. So in the first question I told, the intrauterine pregnancy, there is no any evidence is there. Okay, so that is the reason. And there is mass is noted near the adnexa. So answer, the most common site, that is the ampoule of the fallopian tube. Already we have discussed in detail. Okay, so very important points. So the ovary, second most common site of the fallopian ectopic pregnancy, and the cervix is the least common site of the ectopic pregnancy. Okay, so abdominal cavity also there is when the ectopic pregnancy happens. Okay, this is the rarest one. Okay, so this is the rarest one. Okay, so very important, keep in your mind. Okay, and here is the next important question in front of you, and very well done. Almost all you people have given the correct answer to the first question, that is the big question. Okay, so this is how you people will choose the correct answer, but you will having the fear about the length of the question. Okay, don't get fear about the length of the question, just try to focus over the question completely, and just whenever you will see the big questions, always you have the give the big smile. Okay, so it will relieve your stress, and it will makes you to crave something in that particular questions. Okay, and if you are started digging the question, the answer will be inside the question only. Okay, in the big questions. Okay, very important, keep in our mind, right? The next question is here in front of you all. Yes, which part of the fallopian tube is the most common site of the tubal abortion? So what is the question? Which part of the fallopian tube is the most common site of the tubal abortion? Okay, so remember students, if the implantation is happening inside the uterus, so that will continue as in the normal pregnancy. Okay, if it is happening inside the uterus, it will continue as the normal pregnancy. If the implantation is happening other than the uterine cavity, it will end as an abortion. Okay, so it will end in the first trimester only. It may end as an abortion, or it may end as a tubal rupture. Okay, so two things will happen. One is tubal rupture, means this particular fallopian tube will get rupture, and it may otherwise this particular product of conception will comes out. Okay, so through the fimbria in the peritoneal cavity it will comes out. Okay, so if it is comes out, so that is what you call as the abortion. If it's rupture, so that is what you call the tubal rupture. Okay, anyhow, the particular ectopic pregnancy will end in the first trimester. Okay, so it may end as a tubal rupture, or it may end as the abortion. Okay, so there are the two situations, right? So now I want to answer like, which part of the fallopian tube is most common site for the tubal abortion? Already I have told, very importantly. Okay, so that is the most common site is the ampulla, means most common site for the tubal abortion is the ampulla of the fallopian tube. Remember students, how the ectopic pregnancy in the tubal pregnancy will end. Okay, so this is the uterus. Okay, and here is the fallopian tube. Remember, so this is our fallopian tube. Okay, so this part is called as in the interstitium, and this one is the isthmus, and this one is the ampulla of the fallopian tube. Okay, and here is the infundibulum. Okay, so these are the very important four part of the fallopian tube. Okay, so this one is the fimbria. Remember. Okay, so what are the parts? Just try to label that one. First one is the interstitium, and this one is the isthmus, and this one is the ampulla. Okay, and this one is the infundibulum. Okay, so in this one, ampulla ends as the abortion, and infundibulum ends as a abortion. Okay, and yes, ampulla ends as a abortion, and infundibulum ends as a abortion. Okay, so isthmus and interstitium both will ends as a rupture. Okay, so maximum chance of rupture, maximum chance of tubal rupture. Remember, so last two part, that's the ampulla of the fallopian tube, it will end as in the abortion. Okay, if the ectopic pregnancy is happening in the ampulla, it will lands into the abortion. If the ectopic pregnancy is happening in the infundibulum, it will lands into the abortion. Okay, and interstitium and isthmus, it will lands into the tubal rupture as a maximum chance. Okay, so here's the question. It is asking the most common site which lands as the abortion is the ampulla. Okay, so this is the most common site, and answer goes to the option C as the most common site which lands as a abortion in the tubal pregnancy is the, okay, if the like implantation happening in the ampulla of the fallopian tube, so that goes to the correct answer. Okay, so hope it is clear to every one of you, right? So the next golden point chanting is here in front of you all. Okay, the most common site of the tubal rupture is, yes, the golden point is here in front of you all. What is the most common type of the tubal rupture? Most common site of the tubal rupture. Fatafa do answer to the question. So I told the two sites where there is the highest chance of the tubal rupture. One is interstitium and another one is isthmus. So among these two, which one is having the highest chance of the tubal rupture? Most common site of the tubal rupture is the isthmus. Okay, and in which part of the ectopic pregnancy which ends earlier? Ectopic pregnancy, if it is there in the isthmus, which ends earlier. Okay, and the next one is the which part of the fallopian tube ectopic pregnancy that survives for the longer time. So that is the ectopic pregnancy in the interstitium which survives for the longer time. Sir, why? Why? Because this interstitium which is very much near to the uterus. Okay, and if the implantation happened in the interstitium here, okay, so this particular product of conception, it will get all the nutritive support and all the hormonal support. Okay, why? Because which is near to the uterus, and uterus will provide all the nutritive support and hormonal support to this particular ectopic pregnancy which happened in the interstitium. So that is the reason the interstitium ectopic pregnancy which will survive for the long time. Okay, so interstitium ectopic pregnancy which will survive for the long time. So that is for the duration of the 12 to 16 week. So that is the reason it is very dangerous. Okay, so the dangerous type of the fallopian tube ectopic pregnancy is our ectopic pregnancy in the interstitium, which is the very dangerous, and it will land into the tubal rupture. Okay, it will land into the tubal rupture. Very, very important. But the most commonly tubal rupture will be seen in the isthmus. Okay, so the very important thing, keep in your mind. Okay, so then the last question, that is the overall longer time of the ectopic pregnancy survival will be seen in. Yes, overall longer time of the ectopic pregnancy survival will be seen in the which case? Yes, if the ectopic pregnancy, if it is happening in the abdomen, ectopic pregnancy, if it's happening in the abdomen, in this particular like ectopic pregnancy, that is the abdominal ectopic pregnancy, in this particular situation, we will get the longest time of the survival. Yes, quickly revise the important and golden points. That is, most common site for the tubal abortion is the ampulla. Okay, and the second golden point chanting, the most common site for the tubal rupture is the isthmus. And in which part of the fallopian tube of the ectopic pregnancy which ends earlier? In the 6 to 8 week, that is the isthmus which ends earlier, and which goes longer survival, that is the interstitium. Why? Because which is near to the uterus, and uterus will provide all the hormonal support and all the nutritive support to the interstitial pregnancy. So that is the reason the interstitium pregnancy or the interstitium ectopic pregnancy, it will go as a longest period. Okay, so up till the 12 to 16 week, the pregnancy will long here. Okay, so the next one is the overall longest time of the ectopic pregnancy survival will be seen in the abdominal ectopic pregnancy. These are the very important golden points frequently asked in some medical exams and in the direct questions from your peer other book. Okay, so that is the reason I am doing the golden point chanting, because which was asked in the previous year exams. Okay, so the next question is here in front of you all. Do read the question completely, clearly, and try to give the best answer in the comment box. I'm waiting for your answer in the comment box. So do give the please give the correct answer. Okay, so already we have discussed this one. Yes. Which of the following is the most significant risk factor for the ectopic pregnancy? So which of the following is the most significant risk factor for the ectopic pregnancy? Option A, use of the oral contraceptive pills. Option B, the previous cesarean section. The option C, the pelvic inflammatory disease, and option D, multiparity. So answer goes to the option C, that is the pelvic inflammatory disease as the correct answer. Sir, how in the pelvic inflammatory disease, which is the most significant risk factor for the ectopic pregnancy, sir? Remember, better in the pelvic inflammatory disease, what all other things will happen? So that is one thing, which is our infection and inflammation of the fallopian tube. What we call this one as an infection inflammation of the fallopian tube, that is the salpingitis. Okay, salpingitis. and infection inflammation of the ovary. Okay, that is what we call the oophorytis. And infection inflammation of the endometrium, that is what we call the endometritis. Okay, so that is what we call as in the endometritis. Very, very important thing, just you have to remember. Okay, if the patient is having the endometritis, oophorytis, or the salpingitis, okay, these conditions we and the cervicitis, okay, these conditions we call as in the pelvic inflammatory diseases. So among these pelvic inflammatory diseases, if the patient is having the salpingitis, that is the infection and inflammation of the fallopian tube. So here the infection inflammation have been happen means here the adhesions will formation. Okay, so that is the reason. Okay, if the implantation is like the zygote formation will happens, you know, the most common site of the fertilization is the fallopian tube. In the fallopian tube, again the ampulla of the fallopian tube is the most common site of the fertilization. Okay, so remember the some very important points related to the ampulla. Okay, so ampulla is a very significant part in the fallopian tube. Why? Because it is on the most common site of the fertilization, and it is the most common site of the genital TB in the females, and the most common site of the what we can say the ectopic pregnancy. And very importantly, the ampulla is the widest and the longest part of the our fallopian tube is the ampulla of the fallopian tube. Okay, so usually the fertilization will happens in the ampulla of the fallopian tube. Okay, so with the help of some ciliated columnar epithelium, so this particular product of conception, or we can say the like the fertilized zygote, it will comes to the uterus on the fourth day in the form of the morula. Okay, in the form of the morula, it will comes to the uterine cavity. Yes, tell me in which form zygote will enter into the uterine cavity? Zygote will enter into the uterine cavity in the form of the morula. Okay, on which after how many days after fertilization? It's on the fourth day after fertilization, the morula enters into the uterine cavity. Okay, on the sixth day, this morula become converted into blastocyst. Okay, so this on the sixth day, this morula will get converted into the blastocyst. So this blastocyst will get implant. Okay, so this particular blastocyst, it is in the implantable form. Okay, so this is the implantation form of the our fertilized egg. Okay, so that is the blastocyst is the implantation form. Okay, so this blastocyst will get implant in the this particular or uterus. Okay, if this blastocyst, or we can say fertilized ovum, which is not coming into the uterine cavity. Why? Because due to the salpingitis, the adhesions are there here, and which made the blockage of the particular fallopian tube, and there is in the due to the smoking, if there is in the loss of the cilia. Okay, so in the fallopian tube, you know, in the fallopian tube we have the ciliated columnar epithelium. Okay, so these are the columnar epithelium, and which is ciliated, which are having the hair-like structures. So this is what we call the ciliated columnar epithelium. So this cilia, it will brings this particular ovum, okay, into the uterine cavity, okay. If in case of the smoking, due to the smoking, this cilia will get damages. Okay, so due to the smoking, what happens, this particular cilia, it will get damages. Okay, and there is one syndrome, what we call is on the Cart-Jenner syndrome. Okay, in the Cart-Jenner syndrome, what happening, this cilia become immotile. Okay, so this particular cilia, what I told, the hair-like structure on the epithelium, so this particular cilia are immobile. Okay, so due to this particular situation, the ovum will not comes back to the our uterus, and which makes the patient to get land into the ectopic pregnancy. And the most and main most common cause is the pelvic inflammatory disease and the salpingitis. Okay, so due to the salpingitis, the adhesions will get formed in our fallopian tube, and this particular fallopian tube will get blocked, and that this particular fertilized ovum will not come to the uterus, and it will get implanted into the fallopian tube only, so it may lands into the ectopic pregnancy. Okay, so that is the most common and the most significant risk factor. Okay, so very important, you have to remember. Okay, so here let's quickly divide the and do the golden point chanting. Yes, the most common site of the fertilization, it is the ampulla of the fallopian tube. The most common site of the genital TB in the female, ampulla of the fallopian tube. And the most common site of the ectopic pregnancy, fallopian tube, that is the ampulla is again the most common site. And the widest and longest part of the fallopian tube, ampulla of the fallopian tube. Okay, what is the Cart-Jenner syndrome? Yes, there is in the loss of motility of the cilia is called as the Cart-Jenner syndrome. And how the smoking leads to the ectopic pregnancy. So smoking is the thing which damages the cilia of the epithelium of the fallopian tube. So which damages the cilium is the fertilized egg will not come to back into the uterus. So smoking leads to the ectopic pregnancy. Okay, and normally in normal pregnancy after fertilizations, in which form the fertilized egg enters into the uterus? Yes, the fertilized egg enters into the uterus in the form of the morula on the 4th day. Okay, on the 6th day it will get converted into the blastocyst, and this blastocyst will get implanted into the upper part of the posterior uterus. Okay, so these are the very important golden points what we have discussed now. Okay, so hope it is clear to every one of you, and I am moving to the next question. Here is the next question. So fatapat do response to the question here. Yes, which of the following best describes the serum beta-hCG level in the ectopic pregnancy? Okay, so in the ectopic pregnancy, which of the following which best describes the serum beta-hCG level in the ectopic pregnancy? Very, very important, keep in your mind. Beta, so before going to this particular concept, I want to explain some basic concept to you all. Okay, so that is the beta-hCG is the hormone which is released from the cells called as the syncytiotropoblast. Okay, so there are the trophoblast cells we have in our uterine cavity during the pregnancy. There are the two types of the trophoblast. One is the syncytiotropoblast, another one is the cytotrophoblast. From the syncytiotropoblast of the placenta, our beta-hCG hormone will be produced. So that is the reason syncytiotropoblast we also call as the hormonal factory of the placenta. Okay, so that is a very, very important thing. Just keep in your mind. Okay, so this beta-hCG normally, okay, so normally what happens in the normal pregnancy? Okay, so this beta-hCG every 48 hours, okay, every 48 hours, okay, so this beta-hCG become double. Okay, so double. Consider if this is now 8,000 international unit per liter, means after 48 it becomes the 16,000, okay, international unit per liter. Okay, so this is how what happens in the normal pregnancy. Okay, so every 48 hours, okay, it will becomes double till 10th week of the pregnancy. Okay, till 10th week of the pregnancy. Very important, keep in your mind. But in case of the ectopic pregnancy, okay, the beta-hCG, it will increases, but not get double. Okay, it will not get double every 48 hours. Okay, yes, beta-hCG level will increases, but it will not get double every 48 hours. Consider, so initially it is having the 8,000, okay, international unit per liter. Okay, after 48 hours, after the 48 hours, so it becomes the 10,000, okay, so international unit per liter. Okay, so it is increased from the 8,000 to the 10,000, it increased, but it is not get double. But in the normal pregnancy, what happening every 48 hours, so it is getting double. It is getting double from the 8,000 to the 16,000. Okay, and till the 10th week of the pregnancy, it is getting double. But in the ectopic pregnancy, it is increasing. It is increasing, but not getting double. Okay, so remember, very, very important. And in another situation, there is abortion. Okay, so in the patient with abortion, what happens? A beta-hCG level, it will decreases. It will decreases. It means now if the patient is having the 8,000 international unit of the per liter of the beta-hCG, means if you are checking after 48 hours, okay, so it become the 4,000 international unit. Okay, so means here it is the getting decreased. Okay, so here it is getting decreased. Okay, if the beta-hCG level is getting decreased after the 48 hours, means so that is the abortion. It is getting double, means there is the normal. Yes, it is increasing, but it is not getting double. So that is the ectopic pregnancy. Very, very important thing. Just keep in your mind. Okay, so there is one situation we will study in this particular video only, that is related to the molar pregnancy. In the molar pregnancy, there is abnormal excessive proliferation of the tropoblastic cell will be there. Okay, so abnormal excessive proliferation of the tropoblastic cell means abnormal excessive beta-hCG level will be increased. Okay, so in the ectopic pregnancy, in the molar pregnancy, beta-hCG level which will be more than the normal pregnancy. Okay, here it is getting double every 48 hours, but in that situation it may get triple, or it may get 5 to 6 times double triple. Okay, so in the a case of the molar pregnancy, that one we will discuss. So now just keep the basic concept in your mind related to the what happens in the normal pregnancy and what happens in the abortion, what happens in the ectopic pregnancy. In the abortion, after 48 hours it decreases. In the ectopic pregnancy it will increases but not get double. In the normal pregnancy, every 48 hours it will get double till the 10th week of the pregnancy. So this is the golden point what you have to consider. And now comes to the question and solve the question. Okay, which of the following best describes the serum beta-hCG level in the ectopic pregnancy? So option A, hCG level are always higher than the normal intrauterine pregnancy. Beta, if hCG level is higher than the normal intrauterine pregnancy, so this is just what I told, this is the molar pregnancy. Okay, so this is the molar pregnancy. This is just gestational trophoblastic disorder. So in the molar pregnancy, what happens? Abnormal excessive proliferation of the syncytiotropoblast and cytotrophoblast will be there. So excessive proliferation of the syncytiotropoblast means excessive production of the hCG. So hCG we will get in the molar pregnancy, which is a higher level than as compared to the normal intrauterine pregnancy. Okay, that is in the molar pregnancy we will get the option A. So this is not a part of the ectopic pregnancy. I am eliminating the option A. Okay, so then comes to the option B. hCG level double every 48 hours as the normal pregnancy. Okay, yes, in the normal pregnancy it will get double, but in the ectopic pregnancy it will not get double. So then comes to the option C. hCG level typically rises slower than the normal uterine pregnancy. Yes, so there will be a typically hCG level will rise, hCG level will increases, but not get double. Okay, so but not get double. So this is the very important thing, just we have to consider in our mind, and option C goes to the correct answer. Just now I have explained the thing. Okay, hCG is not produced in the ectopic pregnancy, so this is the false statement. Okay, if hCG is decreasing, so that is the abortion. Hope it is clear to every one of you. Yes, here is the next question. Fatapat do response to the question, which is very important and very simple question. Okay, so that is yes, fatapat do response in the comment box. Which of the following represents the classical triad of the ectopic pregnancy? Yes, this is the important question. What is the classical triad of the ectopic pregnancy? Due to the abnormal and inappropriate site of the implantation, so there will be a abdominal pain will be there. Okay, and there will be a vaginal bleeding will be there, and there will be a history of the amenorrhea will be there. Okay, so this is what we call as the classical triad of the ectopic pregnancy. Yes, so fatapat do response. Why the amenorrhea will be there in the ectopic pregnancy? Better, I want your answer in the comment box. Fatapat. Yes, why amenorrhea will be there in the ectopic pregnancy? But the ectopic pregnancy is also a pregnancy, right? Now in the normal pregnancy, what happens? So we have the more than 25 nanogram of the progesterone. Okay, so progesterone will be there. That is more than 25 nanogram. But in the ectopic pregnancy, yes, the progesterone will be there, but it is less than 5 nanogram. Okay, it is less than 5 nanogram progesterone will be there, but progesterone is present. So progesterone is present means it will not allow the shed out of the endometrium. So that is the reason amenorrhea will be there. Okay, usually there will be a 6 week to 8 week of the amenorrhea. Okay, so followed by the sudden vaginal bleeding and associated with the abdominal pain. Okay, associated with the abdominal pain. So this is the classically picture which represents the case of the ectopic pregnancy. Along with that, the patient is having the shock. Along with this, the patient is having the symptom of the shock, means that ectopic pregnancy has been ruptured. Okay, ectopic pregnancy have been ruptured. Keep in your mind these classical symptoms which help you to choose the correct answer in the exam. Okay, so hope it is clear to every one of you. And here is the next question. Yes, fatapat do read the question completely, then give the best to best answer in the comment box. A 27-year-old woman presents to the emergency department with a severe lower abdominal pain. So what happened here? The 27-year-old woman is there, and just she came to the emergency department again with a severe lower abdominal pain is there, and she is having the dizziness also and vaginal bleeding also it is there. Okay. On examination, she is pale and she is having the hypotension and her BP is 80/50 mmHg and she has the tachycardia. Okay, hypotension is there, tachycardia is there. Beta, wherever there is in the hypotension, okay, so that is tachycardia plus hypotension. So these are classical sign of the shock, or these are the classical sign of the hypovolemia. Okay, so these are the classical sign of the hypovolemia. Remember. Okay, so tachycardia is the earliest sign of the hypovolemia. Very, very important point. Keep in your mind. Okay, in the questions, what happened? In the emergency department, she is complaining of the severe lower abdominal pain is there, dizziness is there, and vaginal bleeding is there. So that is the reason, due to excessive vaginal bleeding, so her color become pale and she is her BP become decreased, hypotensive, and her heart rate become increases and she is tachycardia. And ultrasound reveals there the fluid in the abdomen and empty uterus. Okay, so ruptured ectopic pregnancy is suspected. Ruptured ectopic pregnancy is suspected. So what is the most appropriate immediate management? But whenever we are having the patient with a ruptured ectopic pregnancy, so best management is always resuscitate the patient, and the definitive management is always emergency laparotomy. Okay, and emergency laparotomy, here we will do the removal of this particular fallopian tube. So in the emergency laparotomy, what we will do? We will do the salpingectomy. What we will do? We will do the salpingectomy. Remember. Okay, so always if the patient comes to the ruptured ectopic pregnancy, keep prepare the patient for the emergency laparotomy. Okay, before starting the patient to the emergency laparotomy, make her hemodynamically stable. Why? Because her BP is low. Okay, so whenever the patient comes to the ruptured ectopic pregnancy, so always remember. Okay, so initial management and definitive management. Okay, so in the initial management, what happened? We will establish the two large bore IVC. Okay, that is the IV cannula, and we will instill the intravenous fluid very rapidly, and we will send the blood for the cross matching. Okay, blood grouping and cross matching we will do, and we will arrange for the blood transfusion if necessary. Okay, so these are the initial management. And the definitive management is always go for the emergency laparotomy. Okay, not laparoscopy. I am telling it is in the emergency laparotomy. Means we will open the abdomen. Okay, so completely we will take the large incision. Okay, so we will open the abdomen completely. That is the emergency laparotomy goes to the correct answer. Okay, so we will open the abdomen and we will see where the parts of the ruptured ectopic tube will be there. So we will remove that one. So we will do the salpingectomy. We will do the salpingectomy. So that is the removal of the fallopian tube. So this is the definitive management of the ruptured ectopic pregnancy. Okay, if in case the patient will comes with the unruptured ectopic pregnancy, in that situation we will go for the medical management. So there is the Methotrexate we will give. Okay, so there is the intramuscular Methotrexate we will give, and we will abort it out. Okay, so if it is an unruptured ectopic pregnancy, right? So the next question is here in front of you all. Okay, so the situation I have arranged in front of you. So please do choose the correct answer. Just now I have explained the one thing and I have given the another thing to you to decide. Yes, here the hemodynamically stable woman is there. Okay, so in the last question, a woman is having the tachycardia and hypotension, means she is having in the shock symptoms. Okay, so the already patient is having in the shock. So initially we have managed with the IV fluid. Okay, and we have get the patient ready for the blood transfusion, and we have went the patient for the emergency laparotomy, and salpingectomy we have done as a definitive management in a ruptured ectopic pregnancy. Okay, so that is the emergency laparoscopy we have done. Sorry, laparotomy we have done. In the unruptured, okay, so now this is the situation of the unruptured ectopic pregnancy. Look at this one. A hemodynamically stable woman is there, and she is diagnosed with the unruptured ectopic pregnancy. Okay, now she is diagnosed with the unruptured ectopic pregnancy with beta-hCG level is 1200 international unit per liter, and there is no any fetal heartbeat is there. Okay, or we can say no any fetal heart sound, okay, on the ultrasound. So what is the preferred initial management? Okay, students, whether the baby is live or dead, in the ectopic pregnancy usually baby will die inside. Okay, so in that particular situation we have to remove the particular ectopic pregnancy and we have to abort it out. Okay, so if the patient is hemodynamically stable, okay, if the patient is having the unruptured ectopic pregnancy, in this situation we will go for the medical therapy as the best treatment. So that is the methotrexate therapy. Okay, so this is the best treatment. Okay, it will abort the ectopic pregnancy. Okay, so that is the question will arise in your exam. Okay, as a single line drug of choice for ectopic pregnancy. Drug of choice for the ectopic pregnancy, your answer goes to the again the methotrexate therapy is the drug of choice for the ectopic pregnancy in the unruptured case and in the patient with hemodynamic stability. Okay, so the route of administration of the methotrexate here is the intramuscular we will administer. Okay, so the emergency patient is stable, so there is no need of the emergency laparotomy, and expectant management without treatment is not required here, because if you are leaving the patient without treatment, the patient may land into the rupture of the fallopian tube. Okay, and hysterectomy is not necessary here. So if the patient like completed the complete family means, in that situations this is the like it may be decided by the gynecologist, but here in this particular situation hysterectomy and oophorectomy is not necessary. Okay, so better to decide to continue the patient on the medical therapy, so there are the some rules are there, so we have to make sure that one before before the what we can say deciding the medical therapy. Okay, so here the ectopic pregnancy size should be less than 4 centimeter, and patient should be hemodynamically stable. Okay, patient should be hemodynamically stable, and her beta-hCG level should be less than 5000 international unit per liter. Okay, so this is the criteria where in this situation only we will go for the medical therapy. Okay, so otherwise we will go for the surgical therapy. If the beta-hCG level more than 5000 international units, so we will go for the surgical as the option. Okay, if the patient is hemodynamically unstable, emergency laparotomy. Okay, if the ectopic pregnancy more than 4 centimeter, we can't go for the this methotrexate therapy. We can go for the again the laparotomy. Okay, so that is the very important thing. So this is the criteria we need to check before doing the before giving the methotrexate drug. Okay, so that's the very important thing, just we have to keep in your mind, right? So, and in the fallopian tube rupture, there are the very important two clinical scenario the examiner may create in front of you all. So in the ruptured ectopic pregnancy, remember ruptured ectopic pregnancy. Okay, so I told, or we can say the ruptured tubal pregnancy, this is the uterus and this is the fallopian tube. Okay, and here is the ectopic pregnancy, and here we have the peritoneum. Okay, so this is what we call peritoneal sac or the called sac near the posterior vaginal wall. Okay, so this is what we call as the called sac or the peritoneal sac. Okay, so it is very important peritoneal fold which is near to the posterior vaginal wall. Okay, so this particular bag like peritoneal sac we call as in the called sac. Okay, so here if in case this particular ectopic pregnancy is ruptured, so all the bleeding will get collects in this particular called sac. Okay, so in this particular situation, now the peritoneum is filled with the blood. Okay, so sorry, now the peritoneum is filled with the blood. Okay, so this blood will irritate the peritoneum. Okay, so this blood will irritate peritoneum, and due to the irritation of the peritoneum, we will get the ruptured shoulder tip pain in the ruptured ectopic pregnancy. Remember, okay, so in the question you will get there is in the ruptured shoulder tip pain. Okay, ruptured shoulder tip pain in ruptured ectopic pregnancy. Remember, okay? So one more clinical sign we will get here. This peritoneum is filled with the blood, so it may get the discoloration of the umbilicus area around near the umbilicus. So that is what you call as in the, yes, that is what you call as the Cullen sign. Okay, that is what you call as in the Cullen sign. Cullen sign is the grayish discoloration of the area near the umbilicus. We call that one as in the Cullen sign. So this Cullen sign will be seen in two situations. One is ruptured ectopic pregnancy, and another one is, yes, where we will get, that is, yes, the hemorrhagic pancreatitis. Okay, in case of the hemorrhagic pancreatitis, we will get this particular Cullen sign. Okay, so Cullen sign will be positive in two situations. One is the ruptured ectopic pregnancy and hemorrhagic pancreatitis. Again, in the pancreatitis, the bleeding will happen and it will get collects into the peritoneum and it will leads to the grayish discoloration around surround of the umbilicus. Similarly, in the ectopic pregnancy, the tube will be ruptured and the blood will get collected into the cul-de-sac, and it will again leads to the hemorrhagic pancreatitis like symptoms. Let the Cullen sign will be arised here. Okay, so in order to confirm in the emergency, just we will take a needle and we will insert the needle through the posterior fornix of the vagina and we will get the blood in the syringe. Okay, if we are getting the blood in the syringe while inserting the needle in the cul-de-sac, so that indicates that the blood is there, means a tube is ruptured. Okay, so that is what we call, if we are inserting the needle and we are aspirating the fluid from the body from the what we can call the cul-de-sac, okay, or the peritoneal fold, that is what you call the cul-de-sac. From the cul-de-sac we are doing the aspiration, means we call that one as the cul-de-centesis. Okay, we call this one as the cul-de-centesis. Remember, what is the cul-de-centesis? Is the aspiration of the fluid from the peritoneal fold near the posterior vaginal wall or near the posterior fornix. So that is what we call as in the after inserting the needle from the posterior vaginal wall and posterior fornix from the cul-de-sac we are aspirating the fluid, means that is what we call the cul-de-centesis. Okay, so that is the very important for your upcoming exam. So do remember this particular concept of the ruptured ectopic pregnancy. Okay, so here is the next question in front of you all. So please do read the question carefully, completely, and try to get the best answer in the comment box. Yes, the very important question. Very important question, beta. Which of the following is the most common ultrasound finding in a complete molar pregnancy? Yes, what is the correct answer? Option A, fetal heartbeat. Option B, snowstorm appearance. Option C, the double decidual sign. And option D, the placenta lake. So what is the correct answer? Which of the following is the most commonly seen ultrasound finding in the complete molar pregnancy? Sir, what is the molar pregnancy, sir? Remember, beta. So before going to the a sign of the molar pregnancy, just I will explain what is the molar pregnancy. You will come to know about that one. Okay, so this is our blastocyst. Okay, this is our blastocyst. Inside the blastocyst we have the cells. Okay, so this particular group of the cells, what we call is the inner cell mass. Okay, so what I call this one I call is the inner cell mass. Okay, and these particular cells which are there in the periphery of the blastocyst, these are all called as the tropoblast. What we call this one is in the tropoblast. Okay, so these particular cells, what we call this one is in the tropoblast. In this particular tropoblast, there are the two types of the tropoblast is there. One is syncytropoblast, another one is cytotropoblast. Okay, and one is syncytropoblast, another one is cytotropoblast. Okay, so there is abnormal excessive proliferation of this tropoblast will be there. Okay, so these tropoblast are getting abnormally excessive proliferation. So this is what I call is in the molar pregnancy. Okay, so what I call this one as in the molar pregnancy. Okay, so remember, these sincere trophoblast are the cells which are responsible for the secreting the which hormone? Yes, the which hormone are responsible for secreting the beta-hCG? Beta-hCG will be secreted by which cells? So that is the, yes, beta-hCG will be secreted by the our very important sincere trophoblast. Okay, so remember here, in the trophoblast are abnormally excessively proliferating, means the sincere trophoblast also abnormally excessively proliferate. Okay, so here we call as the excessive release of the beta-hCG will be there, which will be seen more than the normal pregnancy. Okay, so in the normal pregnancy, what I told, there is every 48 hours until the 10th week of the pregnancy, there is doubling of the beta-hCG will be there. But in the molar pregnancy, it may get to the triple or the excessive. More than the normal pregnancy beta-hCG level we will get. Why? Because the trophoblast are abnormally excessively proliferating, and sincere trophoblast are excessively proliferated, and the sincere trophoblast number will be more, and that is the reason our release of the beta-hCG will be more, and beta-hCG level we will get more than the normal pregnancy in the our molar pregnancy. Okay, so what is the molar pregnancy? Molar pregnancy is this particular trophoblast. Okay, so this particular trophoblast which are abnormally excessively proliferating. Okay, so these are abnormally excessively proliferating, so this is what we call as in the molar pregnancy. Okay, so in the molar pregnancy we have the two types of the molar pregnancy. One is complete molar pregnancy. Okay, so another one is the partial molar pregnancy. Okay, so I told this one is the inner cell mass. Okay, this one is the inner cell mass, and this is what we call as the trophoblast. Okay, if inner cell mass also grows, this inner cell mass also grows, and the sincere trophoblast or the cytotrophoblast will get excessively proliferate. Okay, so trophoblast also grows. So here some part of the fetus will grow. Okay, some part of fetus will grow. This is what I call as in the incomplete molar pregnancy, or what I call this one as in the partial molar pregnancy. Okay, so not incomplete, you can write better as in the partial molar pregnancy. Okay, so this is the partial molar pregnancy. Okay, so one situation I told, inner cell mass also will grow, and trophoblast also will grow. Due to the inner cell mass little bit it is also growing, some part of the fetus will grow in the intrauterine life, so that is the partial mole. Okay, so if only this particular trophoblast are excessively proliferating and it is not allowing the inner cell mass to grow, okay, and it is overlapped on the inner cell mass, there is no any inner cell mass, completely excessive proliferation of this trophoblast is there, so that is what I call as in the complete mole. Okay, so or we can call that one as in the yes, complete mole, or yes, what we call that one as in the vesicular mole, or another name of the complete mole or the vesicular mole. Can anyone want to answer? That is the hydatiform mole. Okay, so very important. So there is no evidence of fetus. There is no evidence of fetal growth. Okay, there is no evidence of the fetal growth. Only this trophoblast will be there. So this is what we call as in the complete mole. Okay, complete molar pregnancy, or we can say this is as in the hydatiform mole. Okay, this is what we call as in the hydatiform mole, or I call this one as in the vesicular mole. Okay, so vesicular molar pregnancy also we can call. So very important. Remember, two types of the molar pregnancy. One is some part of the fetus is growing and the trophoblast are excessively proliferating, partial mole. There is no any fetal part, only excessive proliferation of the trophoblast are there. So that is the reason a complete mole or the hydatiform mole or the vesicular mole. I hope the concept is very much clear to every one of you, right? So this is when we will see this particular trophoblast in the USG, so which looks like this. Okay, so look at this particular important USG image. Okay, so which looks like this. So this is the very important USG image for you all. Okay, so this is what we call as in the snowstorm appearance in the molar pregnancy. What I call this one as in the, I will call this one as in the snowstorm appearance in the molar pregnancy. Okay, so the patient will complains after the 6 to 8 week of the pregnancy. Now the patient will complains to us. Okay, so like the grape-like vesicles, coming out of vagina. Okay, so grape-like vesicles means this excessive trophoblast only coming out of the vagina. Okay, so in the history, mother will tell the grape-like vesicles are coming out of the vagina, and whenever we will see the ultrasonography of the complete mole, we will get the snowstorm appearance. And when we will check the beta-hCG, okay, so beta-hCG level will be more than the normal pregnancy. Okay, it is more than the normal pregnancy. Very important, keep in your mind, right? So the next important point what you have to keep in your mind, I told it is in the abnormal, it is in the excessive proliferation of the cells. Means whenever we will check the height of the uterus in the this what we can say molar pregnancy, height of the uterus is more than the period of the gestation. Okay, so consider, okay, so in the normal pregnancy, height of the uterus at the 20 week will be at the level of the umbilicus, you consider. Okay, in the molar pregnancy, height of the uterus in the 20 week will be, okay, it will comes near the GP sternum. Means in the normal pregnancy it will be at the level of the umbilicus. Now it is at the level of the GP sternum. Means in the ectopic pregnancy, the height of uterus is more than period of gestation. We will see in case of the molar pregnancy, because of the inside there is abnormal excessive proliferation of the our trophoblast will be there. So that is the reason the molar pregnancy, we also call this one as in the a gestational trophoblastic disease. What is the another name of the molar pregnancy, beta? It is in the gestational, means due to the pregnancy. Okay, that is the gestational trophoblastic disease. Okay, so hope it is clear. Molar pregnancy we also called as the gestational trophoblastic disease. And the history while checking the per abdominal examination, so the height of uterus is more than the period of the gestation. Okay, so the beta-hCG level will be more than the normal pregnancy because of the abnormal excessive sphincter trophoblast. Along with that, the grape-like vesicles coming out of the vagina will be the classical symptom will be told by the mother when we will do the ultrasonography of the US mother abdomen, where we will get the snowstorm appearance. Okay, so this is the very important thing, just we have to keep in our mind. Okay, so hope it is clear. Then comes to the some golden point chatting. Okay, height of the uterus in the molar pregnancy. Yes, what happens here? More than period of the gestation, more than period of gestation. Just you try to understand the concept, so everything will be easy. Okay, beta-hCG level in the molar pregnancy, so what happens? More than normal more than normal pregnancy. Okay, more than normal. Why? Because in the molar pregnancy there is abnormal excessive proliferation of the sphincter trophoblast is there. So sphincter trophoblast is the cell which is responsible for the releasing the hCG. More sphincter trophoblast in number, more hCG in amount. Okay, so very important, keep in your mind. Okay, so then chromosomes in the partial mole, what happens? So you have to keep in your mind, so how the partial mole will be produced and how the complete mole will be produced. Okay, so let me explain the concept, so it will be very much easier for you all. So first I will explain the partial mole. Okay, so then comes to the complete mole, complete molar pregnancy. Okay, so let me explain the concept just behind this one, so you will be very much clear about this one, right? So what happens in the partial mole? So there is one ovum is there, okay, which is having the 23 number of the chromosomes. Okay, for this one ovum there are the 2 sperm, it will comes. Okay, so which is also having the 23 number and the 23 number of the chromosomes. Okay, so one ovum, 2 sperm, which will fertilize and it will make the zygote which is triploid, okay, which is triploid. So in the partial mole, the chromosomes are triploid. So in the partial mode, what happened? The extra genetic material which is coming from the father, okay, which is coming from the father. Remember, okay, and it is bispermic, okay, which is bispermic. Remember, it is in the bispermic because there are the two sperm which is penetrating the ovum in the partial mole. Okay, so very important. The partial mole is bispermic. Partial mole is triploid, and the partial mole extra genetic material which is coming from the father. Okay, so in the complete mole, what happens? There is a ovum which is empty. There is a ovum which is empty. Okay, and for this one, there is a sperm with 23 number of the chromosome. It will comes and it will penetrates. Okay, after that, this sperm will get diploid. Okay, so after that, the chromosome numbers in the sperm will get double, and so this particular complete mole is because of the diploid. Okay, so it's not in triploid, it is in the diploid. Why? Because there are the only two pairs of this chromosome is there, so I call this one as in the diploid. Okay, so this is the diploid, and here there is the only one sperm is there. Okay, so this is the monospermic. This is the monospermic. Remember, very important thing. Complete mole is monospermic. Complete mole chromosomes is diploid. Okay, so the partial mole was triploid and the complete mole is diploid. And I told in the partial mole the extra genetic material which is coming from the father, but it is in the complete mole entire genetic material which is coming from the father only. Okay, so there is no genetic material from the mother. No genetic material from mother. Why? Because ovum is empty here. Okay, so why? Because ovum is empty here. So very important. That is the reason there is no any genetic material will be there from the mother. The complete genetic material will be from the father only in the complete molar pregnancy. Okay, so hope this particular golden chain pointing is very much important. Okay, height of the uterus in the molar pregnancy is more than the period of gestation. Beta-hCG is more than the normal. Chromosomes in the partial mole is the triploid. Chromosomes in the complete mole is the diploid. Chromosomes sperms in the partial mole is bispermic. Sperms in the complete mole is monospermic. Okay, so these are the very important points. So just you have to keep in our mind. Okay, so the next question is here. Which of the following is not a typically associated with molar pregnancy? Option A, the thecal lutein cyst. Option B, elevated HCG. Option C, large gestational age for uterus. And option D, low beta-hCG level. So what is the answer for this one? Which of the following is not associated with molar pregnancy? Option A, thecal luteal cyst. Option B, elevated HCG. Option C, large for the gestational age uterus. And option D, low beta-hCG level. Low beta-hCG level we will not get here. We will get here is the high beta-hCG level. Okay, so which is not associated with the molar pregnancy. Okay, sir, what is the thecal lutein cyst, sir? So please remember this particular concept, which is very much important for you all. Okay, here. So remember this beta-hCG. Okay, this beta-hCG, it is excessively increased. It is excessively increased, and this beta-hCG it will act on the ovary. Okay, so now on the ovary bilateral side, I means in the both ovary, we will get the theca luteal cyst. Very important. Okay, and this beta-hCG is excessively increased. So means what happens here? There is excessive vomiting in pregnancy. So this is what we call as in the hyperemesis gravidarum. we will get a patient with hyperemesis gravidarum, very important, and a beta hCG level which is actually similar in the structure and function of the our thyroid stimulating hormone. Okay, so in the ectopic, in the molar pregnancy, the beta hCG level is excessively increased, means it will works like as in the thyroid stimulating hormone. Okay, so the thyroid function will be abnormally increased. Okay, so there is abnormal increase in the thyroid function, and the patient may land into the thyroid toxicosis. Thyroid toxicosis in pregnancy, that is due to in the ectopic pregnancy. Okay, so very important concept, just we have to try to remember here. The thecal luteal cyst in the ovary is due to the abnormal excessive action of the beta hCG on the ovary, which makes the thecal luteal cyst bilaterally, and excessive vomiting. Okay, so that is the hyperemesis gravidarum we will get due to the abnormal excessive hCG level in the what we can say in the case of the molar pregnancy, and beta hCG unit is similar to the thyroid stimulating hormone. Okay, so we will get the abnormal excessive thyroid function, so it may make the patient to land into the thyroid toxicosis, or which may make the thyroid storm during the pregnancy. Okay, which may make the thyroid storm during the pregnancy, so due to the abnormal stimulation to the thyroid gland by the beta hCG level. Okay, so hope it is clear to every one of you. And the second one, I think the luteal cyst is clear. Elevated hCG level I told because of the abnormal excessive proliferation of the trophoblast. Since the trophoblast is more, excessive hCG will be there. Okay, and I told the large for gestational age uterus because the trophoblast are abnormally excessively increasing. Okay, so the height of the uterus is the more than the period of the gestation. Okay, so the concept already I have explained here. Okay, so high because here the abnormal excessive proliferation is there, so that is the reason height of the uterus is the more than the period of the gestation. Okay, so this is the concept what I have already explained to you people here. So hope this particular question is clear to every one of you. And which is not associated in the molar pregnancy is the low beta hCG level is not associated in the molar pregnancy. Okay, so here is the next question. So fatapat do read the question and give the best answer for this question. Yes, today's session will go little bit longer because it is important. I want to cover this one, okay, before the exam. That's the reason. Okay, so which of the following is the malignant complication that can arises from the molar pregnancy? Beta, so molar pregnancy, it is the benign. Okay, so molar pregnancy means the partial mole what we have studied and the complete mole what we have studied. So both are the case of the benign. Okay, so both are the benign tumors. It may get converts into the malignant. Okay, so it may get converts into the malignant. Okay, which is having the highest chance of get converting into the malignant. So which of the following condition or the complication that can arise from the molar pregnancy? Option A, placenta previa. Option B, endometrial hyperplasia. Option C, ectopic pregnancy. And option D, choriocarcinoma is the molar pregnancy, which is a malignant form. Okay, so the most common malignant form is the benign. Sorry, so that is our gestational trophoblastic neoplasia. This is the most common malignant type of the molar pregnancy, and this is the second most common malignant type of the molar pregnancy is the choriocarcinoma. Okay, so very important, keep in your mind the molar pregnancy to become a malignant. Okay, so that is the chance how much in the partial mole, so it may get converts into the gestational trophoblastic disease, that is the 4% chance is there, and the partial mole may get converted into the choriocarcinoma, less than 1% chance is there. Okay, so that is the reason gestational trophoblastic neoplasia is the most common malignant form of the molar pregnancy. Okay, so the complete mole, it may get converts into the gestational trophoblastic neoplasia, that 15 to 20% chance is there. Okay, the complete mole may get converted into the choriocarcinoma, so there is in the 4% chances there. Okay, so very important, keep in your mind. So this was the already asked exam. Okay, it is in the important. Okay, so what is the percentage of the chance of the getting converting into the malignancy from the molar pregnancy? Okay, hope it is clear to everyone. Yes, so the next one is here. Okay, so what is the first line treatment for the diagnosis of the molar pregnancy? Whenever the patient will comes with a molar pregnancy, yes, The first line treatment is option A, expectorant management, option B, methotrexate chemotherapy, option C, suction and evacuation, option D, hysterectomy in all cases. No beta. So always first and best treatment, okay, that is the suction and evacuation followed by the dilatation and curettage. So this goes to the correct answer. And remember, this question have been already asked in the exam, okay, so there is chance of striking in the again in the Norcet line also, okay. So what is the first line treatment for the diagnosis of the molar pregnancy? So diagnosed molar pregnancy, that is the suction and evacuation we will do, okay. So that is the very important. And after the suction and evacuation, okay, so what we have to advise? So we have to advise a weekly Beta-hCG level, okay, weekly Beta-hCG level we will advise, okay, until it comes to the normal, okay, until it comes to normal, okay. And after coming normal, monthly Beta-hCG level we will advise, okay, monthly Beta-hCG level we will advise. So this one till the 6th month, this one till the 6th month we have to advise to the mother, okay. So that is the reason in the molar pregnancy 6 month next pregnancy is contraindicated after the suction and evacuation, okay. So in the case of the molar pregnancy, we are doing the suction and evacuation. After doing the suction and evacuation, 6 month pregnancy is contraindicated in the molar pregnancy, okay. So if it is choriocarcinoma, in the choriocarcinoma, so if the patient have been diagnosed with the choriocarcinoma, next 1 year pregnancy is contraindicated. So we will advise the mother to not to conceive for the next 1 year if the patient is having the choriocarcinoma, and if the patient is having the molar pregnancy, so that is the benign form of the molar pregnancy. Here we will advise to not to conceive for the next 6 months, which is very important advice we have to give to the mother, okay, after the suction and evacuation of the current molar pregnancy, okay. Hope it is clear to every one of you. And here is the next question. I told just so every weekly we have to do the Beta-hCG level till it comes to the normal, okay. So after coming it normal, every month for the duration of the 6 months we have to do the Beta-hCG level, okay. If it is comes to the normal, that is the good. If it is not come to the normal, that indicates the it may get converted into the malignant tumor, okay. So the next question is here in front of you all. What type of the contraception is recommended during the follow-up of the molar pregnancy, okay. So in the follow-up of the molar pregnancy, we will do the suction and evacuation. After doing the suction and evacuation, I told the next 6 month pregnancy is contraindicated, okay. So during this particular time, we will advise them to take the hormonal oral contraceptive pill. So this is the best recommended contraceptive after the molar pregnancy, okay. So remember in your mind, okay. So remember when the Beta-hCG will comes to the normal, okay, after the suction and evacuation, what is the time duration where the beta human chorionic gonadotropin it will comes to the normal, okay, after suction and evacuation, when it will comes to the normal. If we have done the suction and evacuation of the partial mole, it will comes to the normal within 7 weeks, okay. If you have done the suction and evacuation of the complete mole, it will comes to the normal within 9 weeks, okay. So in the complete mole, the Beta-hCG level will comes to the normal within 9 weeks after doing the suction and evacuation, and in the partial mole, it takes the 7 weeks to come to the normal Beta-hCG level, okay, after doing the suction and evacuation of the partial mole, okay. So this is a very important concept. So just keep in your mind, okay. So just try to keep in your mind this one because it is very important, okay. So the next question is here. Fatapat do response to the question. In a woman over the 40 years with a completed family and diagnosed with a complete mole and definitive management may be. So beta, in the complete mole, so this is having the 15 to 20% chance to get converted into the gestational trophoblastic neoplasia, okay. So this is the malignant form. This is the malignant form, and this complete mole which is having the 4% chance of getting converting into the choriocarcinoma. right? So this complete mole is dangerous, right? Why? Because this is the benign, it may get converted into the a choriocarcinoma. So in this particular situation, if the woman is 40-year-old and she is having already a completed family, means she have completed her all the deliveries, and she is having the good 2 or 3 normal child, okay? So and she is diagnosed with the complete mole, so the definitive management, we will go for the a total hysterectomy, okay? We will not leave the any chance behind to get converted into the metastasis and get converted into the malignant tumor, okay? So that is the reason the definitive management here is a total hysterectomy, okay? So keep in your mind better, and remember the most common metastatic site of choriocarcinoma is, the most common metastatic site of the choriocarcinoma is, yes, the answer goes to the lungs, okay? So answer goes to the lungs. So that is the reason in the choriocarcinoma, when we will do the chest x-ray, when we will do the chest x-ray, when we will do the chest x-ray in the choriocarcinoma, okay? So we will get the snowstorm appearance of the lungs, okay? Yes, we will get the snowstorm appearance of lungs. Very important point for your upcoming exam, okay? Keep in your mind, snowstorm appearance we are getting in the USG, that is the complete mole, and snowstorm appearance we are getting in the chest x-ray after the diagnosis of the choriocarcinoma. So that is the choriocarcinoma, and which is the most common site of metastasis of the choriocarcinoma is the, yes, that is our lungs. So that is the reason. So the lungs cancer, the cancer of the our gestational trophoblast which converted into the malignant, that is the choriocarcinoma, which have spread to the lungs. So that is the reason where the lungs we are getting as a snowstorm appearance, okay? So snowstorm appearance of the lungs indicates the choriocarcinoma. Snowstorm appearance in the USG pelvic indicates the a very important complete molar pregnancy, okay? So what is the tumor marker for the choriocarcinoma? What is the tumor marker for the choriocarcinoma? Yes, already discussed points in the oncology. So anyone wants to answer what is the tumor marker for the choriocarcinoma? So that is the very important Beta-hCG, okay? So Beta-hCG is the tumor marker for the choriocarcinoma. Remember, very important point, right? So these are the very important points what we have discussed today in the today's session, and I am giving some important assignment to you all. So please do note the assignment and mention in the comment box, okay? So the first assignment is here in front of you all. Most common site of ectopic pregnancy overall dash, okay? So second is most common site of second most common overall site, okay? So this is the second most common site of ectopic pregnancy dash, okay? So already we have discussed this one. I want you people to remember and give the best shot in the comment box after the end of this particular class, okay? So and the next question is the most common site of metastasis of the choriocarcinoma, okay? So most common site of metastasis of choriocarcinoma. So these are the very important 3 questions which is there in your assignment of the today's class, okay? So at the end of the class, please do comment the answer in the comment box, okay? If it is right, I will give the thumbs up and I will send love from my side, okay? And if it is wrong, I will correct you people there also, okay? So don't worry. And today's session, I hope every one of you have enjoyed. This was the slow and perfect session. Why? Because so this is the concept based session. That is the reason I want you people to and get exposed to the concept and understand the concept, so that will help real in the exam. Okay, so hope you people enjoyed the today's session. We will again meet in the tomorrow session with a very high yield and very important questions and concept for the upcoming Norcet exam. So stay connected, stay motivated, keep preparing, work hard. Yes, the definitely result will be yours. Okay, and don't forget, if you are not a part of our WhatsApp group and Telegram group, the link I have given in the description box, you can join there. And if you want to become a successful aspirant and to become a nursing officer, and if you want to become a successful nursing officer in the Norcet 9, so please do join to our Super 60 test series, which is there in the Master Nursing Classes app. The app link also I have given in the description box. So thank you so much for watching the class till the end. Happy learning. Stay connected, stay motivated, keep learning, keep practicing. Yes, the result will be yours. Bye bye. Thank you. Jai Hind, Jai Bharat.